Welcome and thank you for joining today's webinar on jail reentry for people with substance use disorders, Part 3, sharing and using data with the National Association of Counties and the Institute for Intergovernmental Research, funded by the Bureau of Justice Assistance. This is the last webinar of the three-part webinar series hosted this March. My name is Elin Lee, and I'm the Program Manager for Justice at the National Association of Counties. Before we get started, just a reminder that this session is being recorded and will be available on the NACo website after the event. Please feel free to use the chat box feature to pose any questions you may have throughout the webinar, and we can address them during the Q&A portion of the session. During today's webinar, you will hear from experts and leaders highlighting strategies counties can implement to use and share data for making strategic policy decisions and enhancing coordination of treatment and services to support recovery and improve individual outcomes. First, I would like to pass it over to Kathy Rowans from IRR to introduce herself and for opening remarks. Kathy?
Thanks, Elin. Hi, everybody. My name is Kathy Rowings. I'm a Senior Research Associate at the Institute for Intergovernmental Research. We provide training and technical assistance to sites across the country under the Bureau of Justice Assistance's Comprehensive Opioid Stimulant and Substance Abuse Program, or COSAPP, which is what I will refer to it from here on out, because that's a mouthful. Just wanted to hop on and provide a quick overview of COSAPP, since you're going to be hearing from two sites that are funded under this grant program, and we think it's a great funding opportunity that many of you may want to think about applying for in the future. So the big overview is that COSAPP provides financial and technical assistance to states, localities, and tribal governments to help them plan, develop, and implement comprehensive efforts to support those impacted by substance use disorder. So what that sort of looks like in the real world is that since 2017, the Bureau of Justice Assistance through COSAPP has supported work that aims to reduce overdose deaths, to promote public safety, and to support access to treatment and recovery services in the criminal justice system. And they've done this through over 500 site-based projects and demonstration projects across the country. Site-based projects, those grants are really kind of the cornerstone of the COSAPP initiative. These are released annually, and they provide funding opportunities to both states and territories, as well as local and tribal communities. This COSAPP funding is designed to be flexible and to allow each community to address its unique needs and to respond to emerging threats that are local or regional in nature. And then for the demonstration projects, there are about 60 of those. BJA and various partners developed those projects to strategically blend funding from multiple federal agencies, and in some cases to promote public philanthropic partnerships. So there are demonstration projects focused on rural communities specifically, focused on helping jurisdictions implement the overdose detection mapping application program, or ODMap, which I think you'll hear a little bit more about as well today, focused on building connections between jails and community-based treatment, and a handful of other sort of targeted topics. So like I said, today you'll be hearing from two sites that are funded through COSAPP. First, you're going to hear from Reno County, Kansas, which is a participant in the Rural Responses to the Opioid Epidemic Demonstration Project. The RROE initiative supports 21 rural sites across the country as they have worked to identify gaps in prevention, treatment, and recovery services for individuals with SUD. And then they've either enhanced or implemented activities to help fill those gaps, and again, really just enhance their efforts to address the substance use crisis in their communities. And then you'll also be hearing from Dupage County, Illinois. They received a COSAPP site-based grant, I think in 2019, they can correct me if I was off on that, to help the health department do a whole bunch of stuff, which you'll hear more about later. But one that I would highlight is working to sort of implement a data management team, a process to help unify disparate data sources related to opioid use in the county. I think lots of folks on the call listening in are probably grappling with this disparate data sources issue. So we'll look forward to hearing from both of those sites about how they're using data in a way to help enhance treatment and services. So what you're looking at here on the screen is just the website where a lot of this great information is housed, COSAPPResources.org. There's tons and tons of information on here. There's publications, there's webinars, there's site profiles, there's podcasts. So we really encourage you to visit this site, dig through all of those resources. You can also learn more about COSAPP as a whole. Next slide, please. And then, yes, so on this slide, you can just see a little bit more detail about some of the resources available through COSAPP. And what I want to make sure to highlight is the training and technical assistance, tailored assistance. You do not need to be a COSAPP grantee to request TTA and support through this mechanism. We have lots of partners, lots of other sites doing similar work, lots of resources that we can connect you with to support your work to address SUD in your community. So if you have any questions that you've been trying to figure out, information you're interested in that you just like don't have the time to Google for it, don't hesitate to reach out. We're here to help and happy to do so in whatever way we can. You can also learn more about upcoming funding opportunities. We're, I think, sort of heading into grant season. So this is a nice, I don't want to call it a clearinghouse, but there's a lot of information about upcoming funding opportunities housed in one space to make it easier for you to find. And then also we have a listserv that would encourage folks to sign up for, so you can get all sorts of information sent directly to your email box. And that is it for me. Just wanted to give a quick overview of these projects and COSAPP before you get to hear all the cool details of the great work that's being done by these grantees. So I will happy answer questions at the end, but otherwise I will turn it back over to Elin. Thanks.
Thank you, Kathy. I would now like to introduce you to the speakers of today's webinar. First, we have Seth Dewey, who is a health educator of substance misuse in Reno County. Seth, would you like to introduce yourself?
Yes, hello. My name is Seth Dewey, and I, like she said, am working at the Reno County Health Department, and I'm a project coordinator for the COSAPP project here in Reno County, Kansas.
Thank you, Seth. Next, we have Jeff Latta, who is an assistant director of adult outpatient services in Dupage County, Illinois. Would you like to introduce yourself, Jeff?
And once again, helps to unmute. Hello, everybody. My name is Jeff Latta, and I'm the Assistant Director of Adult Outpatient Services for the Dupage County Health Department. I oversee all of our counseling, substance use, mental health programming that includes our forensic behavioral health program and a number of other initiatives that are direct partnerships with criminal justice initiatives.
Thank you, Jeff. And thank you both for being here today. We now can go into the presentation portion. I would now like to kick off presentations and pass it over to Mr. Dewey.
All right. Well, like we already covered, my name is Seth Dewey, and I'm, first of all, just want to say how grateful I am to be here talking to you all about sharing and using data. Like she said, and I said as well, I'm the project coordinator for this particular project. And what we've learned in the time that we've been working with this COSAPP funding opportunity is we've learned that data and stories come together. One of my friends, he always says, the data tells, but the stories sell. And I kind of always push back. I'm like, but the data gives us the story to tell, right? And that's so true. So we need both of them. So what I'm going to try to do is paint a little bit of a picture to convey a little bit of both the data and the story that we're telling here in Reno County that has been made possible by this project and the help of Kathy and the COSAPP project. So if you want to go on to the next slide, we'll start that little story with some data. And these are the numbers that unfortunately right now we're all seeing in this line of work. Particularly, we're hearing over and over again the rising overdose fatality numbers, and we're going to hit on those again for emphasis. You know, repetition is the mother of retention, and this is something that we do need to retain to keep our focus on what we want to change. So 104,000 overdose deaths in a 12-month period. It's 285 a day. 285 a day. I remember when I first got into this work was right around 2017 when we had then was the highest of, what was it, 72,000 overdose deaths in a year. And everyone was like, oh my goodness, that's as many as American troops that we lost in the Vietnam War. And it was terrible. And we couldn't fathom it at the time. And yet here we are with 104,000. And here in Kansas, Reno County, Kansas, it's always been said before, well, that's a problem on the West Coast, or that's a problem on the East Coast, or that's a problem in the big cities. Some of us have always said, no, it's here, but we just didn't have the data. And now that we're collecting the data, we're seeing that. So the Kansas provisional data from the first 6 months of 2021 showed 338 deaths. And this is a rural state. That's a 54% increase in the same 6-month time frame from 2020. 54% increase. Kansas right now is number 3 on the highest percent increase. Not totals, mind you, but increase. And that's a cause for alarm for us here in Kansas. The only other states ahead of us are Alaska and Vermont. If you want to go on to the next slide. So, like I said, I kind of got started into this work in 2017, and in 2018 in Reno County, Kansas, we noticed a lot of anecdotal data or stories being told of people that were passing away of overdose. But at the time, it was just coming from those in recovery and people's family members, and the stories weren't always matching up with what we had for the data. In 2020, January to be exact, I was hired on to the Reno County Health Department, and I wondered, along with the help of our public health analyst and some others here in the community, what it would be like and what programs there were for us to start collecting that data to be able to prove these things that we were hearing from the people who were living these situations. That's when I was personally introduced to ODMap. And ODMap is an overdose mapping program that was brought to light by the Baltimore, Maryland HIDTA, which is high intensity drug trafficking area, that allows for agencies, reporting agencies, to record overdose data and be able to view it in real time. And there's a little sample picture of it there on the screen. So we started having these internal conversations. And in those internal conversations, like they often do, they got out to our coalitions and they got out to other members in the community. And on October 1st of 2020, Reno County EMS, our emergency medical services, onboarded to ODMap. And this was a huge win for us. We were so happy. And then local harm reduction coalition paired up with the health department and Kansas Recovery Network, which was at the time Addicts Against Overdose, started working with the health department and entering in overdoses as well on this program. And then January of 2021, the county coroner got on board. And all of a sudden, we started seeing a different picture. We started having some validity to those stories that we were hearing prior. Next slide, please. But we were still stuck with the issue of, well, what do we do with this data? Well, enter in this public dashboard. This pretty thing right here that was introduced by our public health analyst, DJ Gehring, who was able to put all this information that we were seeing into this dashboard that was available to the public. Our any community member could go here and see this. And this has opened the door for conversations with our law enforcement, with our prevention networks, with businesses, and how it affects economic development. This was a game changer for us. This was an amazing opportunity for us to be transparent, authentic, and true to our work at the Public Health Department. Some of those things were not things that you would necessarily want to talk about in your community, but what we found is having these hard conversations were very, very important. How so, you might ask? Well, if we go on to the next slide, it allowed for us to start using our data in ways that we had to get creative with. Just like that dashboard was something that took a lot of planning and had some pushback at first. The same is true with how we started using that data besides the dashboard. Anyone familiar with ODMap knows that you can set a criteria for your area. And that criteria can range from over a certain amount of overdoses in a 24-hour period, or if you're having a lot of overdoses, maybe you just are tracking fatalities. But the important thing is it's something that can be changed. So for us in Reno County, we established a criteria of 3 overdoses that met a certain criteria within a 24-hour period. So for instance, if they were of the same substance or suspected substance, we would go ahead and put that out to the public in the form of a press release. Now, something that we had talked about before in other circles is the work that goes on before all this, right? So we already had a community coalition called the Reno Recovery Collaborative. Now, this collaborative is made up of law enforcement, members of our Chamber of Commerce, schools, prevention coalitions, fire and EMS, the county coroner, harm reduction coalitions, and the list goes on and on. So we approved this spike criteria through that collaborative. And once that was approved, they gave us at the health department the okay to go ahead and put forth press releases like this. And we also discussed the content. So we would be honest and transparent with what we're seeing. So for instance, if it's a suspected synthetic opioid like fentanyl being mixed in with counterfeit pills, we would go ahead and let the community know that. But also we encouraged the same things that other areas are using right now as effective strategies. For instance, naloxone trainings and naloxone availability, checking on people who use substances and encouraging ones who do use to not use alone. These have been very instrumental. And if you want to go on to the next slide, one of the things that we started utilizing as well as this program called the Recovery Response Team. Now, this team includes a dual certified person-centered case manager, also a peer support or a peer mentor for mental health and substance use, and then of course the program coordinator. Now, this is being used headed off by a local mental health and substance use facility. And what they're able to do is they're responsible for making contact with individuals who've experienced an overdose within 24 to 48 hours of an event. Now, of course, this requires a lot of collaboration. So we have all of our providers that are linked in with this program, as well as our EMS, our police, our crisis response team with the local police department, and so forth. And if you want to go to the next slide, this is where we're going to get more into our vision. I know that this particular presentation is geared towards jail and reentry, right? Well, unfortunately, we're still in that process of trying to figure that out. But once again, the transparency, we're going to talk about where we want to go and some of the successes that we have seen so far. So this graph shows just the prevalence of incarceration, for instance, in Kansas. And here in Reno County, we do have 3 relatively large facilities. So, and a large jail as well. So this gives an indicator of the number of individuals incarcerated in Kansas right now. And with that statistic over here, that post-release opioid-related overdose mortality is the leading cause of death among those that are being released from jails and prisons. So one of the things I would like to say that has happened since I made this the slideshow is the recovery response team has also been able to start making contact with the local jail upon those individuals being released as well. So that's a process that has just developed. So a little bit of our vision is becoming a reality. And if you want to go to the next slide, this is where we're also noticing having a great success as well as with our local recovery housing. Here in Kansas, the predominant recovery housing option that there is Oxford House, which is a democratically ran self-supportive home for recovery. And up to 90% of individuals that are living in Oxford houses have experienced previous incarceration. Oxford House has an amazing reentry program, especially, for instance, here in Reno County, where we have a great relationship built up with our local prisons, as well as our jail, offering a safe, supportive environment for those to get involved into recovery housing immediately upon release. And we know that that window of time is so small. And the reason I say that is, aside from what I do in this work now, I'm also a person in long-term recovery. And what my path of recovery looks like for me is I haven't felt the need to use a substance since July 23rd of 2017. So when I was released from the Reno County Correctional Facility and made my way to an Oxford house, it was the missing link for myself. And so what we've been able to do is really capitalize on some of these relationships that were already there and that were formed out of necessity. And now we're continuing that necessity and making that known to our community. And we couldn't have done that without a lot of these options that have been made available to us through this particular project. So now we get into the exciting part, or the part that I find exciting. And we'll get into that in the next slide real quick. All right, so we're going to talk about looking ahead. So what we're wanting to do is have, of course, increased programs while incarcerated. We have another individual who's in recovery that's leading the programs at the Reno County Correctional Facility. And so we're increasing our peer mentor programs that are available within the Reno County Jail. And then also the new one that we're researching is medically assisted treatment while incarcerated. This is something that we've gotten a little bit of backlash in the past, and now we're having a lot more success with open ears as far as the information we're being able to share based off of some of the information we've received off of the calls with these various sites through COSAPP. So it's been very instrumental. Another thing that we're working on with one of our local harm reduction coalitions, our goals is giving out overdose prevention kits upon release. And of course, improving our enrollment in programs before reentry and coordination with recovery housing options. So that's going to, that would entail, of course, bolstering our reentry programs here in Reno County. Now, I want to conclude with the statement that Kansas is doing some amazing things throughout, but it's been a true blessing to be able to work with COSAPP and get some of that funding to increase some of these efforts, mostly in the way of means with our community, because what that's done is it's put a face to people in recovery by empowering them, but it's also empowered people who've never been affected by substance use disorder to see what is actually going on in our community and how they can be a part of the solution. Now, in that final slide, there are some resources and of course my email as well. And I would welcome anyone to be able to shoot me an email. And that's all I got. Thank you so much.
Thank you, Mr. Dewey. I appreciate it. A lot of great content here. Next, we'll have Mr. Latta to share his efforts in Dupage County.
All right, thank you. So again, good afternoon, everybody. As I stated at the beginning of the hour, my name is Jeff, and I'm the Assistant Director of Adult Outpatient Services with the Dupage County Health Department. Next slide, please. So in case you're not familiar with Dupage County, we are located just west of Cook County, the home of Chicago. We are the second most populous county in Illinois, with just over 900,000 people. And our main county government campus is almost right dead center in the county, where our correctional facility is located, and one of our several treatment offices, actually I should say two, because we have two separate locations, two separate buildings all on the same campus, where we provide the majority of our behavioral health treatment. It's also where our forensic behavioral health program is located, which our mental health and substance use reentry program operates out of, which is kind of a bridge right in between our offices here and our correctional facility. And I say our program because our program, mental health, our behavioral health reentry program, is really a partnership between the health department and with our DuPage County Sheriff's Office, who has the oversight of our correctional facility. Next slide. So just like every public health department, you know, we have the full array of the core services that are required for public health, you know, from community health resources all the way through communicable disease and epidemiology, which of course has been a huge focus of time and energy and effort over the last couple of years. But something that's a little bit different about our health department that I do know that other public health departments have, some of them do, but not every health department has, is we also house our behavioral health services programs in the health department. So our main target population who we are working with are those who we refer to as being our safety net population. They're often, they often have Medicaid, or they're underinsured or uninsured, which has really helped us become a very natural partner with a number of our community, number of our law enforcement organizations, including our Sheriff's Office. Next slide. So our behavioral health services programs really offers a full continuum of treatment, all the way from youth, early intervention, all the way through adulthood, as well as far as intensity of treatment, from outpatient treatment, case management, through on the mental health side, we do intensive community-based work, as well as a full residential program. In our substance use programs, we offer medication-assisted recovery, as well as early intervention outpatient and intensive outpatient. We also have a forensic behavioral health component to our adult outpatient services, which I'll refer to a little bit later today. Our medical services program offer a full array of psychiatric services. So we're lucky to have a great team of psychiatrists and nurse practitioners. And then last but not least, our emergency services program, which is a real important piece to what we offer, because we're often bridging people from our correctional facility and reentry into our crisis system, which allows for a much more immediate and quick response to help somebody. So we have a 12-bed emergency respite unit here right on the same campus of our correctional facility. And we also have a mobile crisis response that allows for us to partner with a number of our law enforcement municipalities across the county. And then last but not least, our crisis hotline. We are also a provider of the National Suicide Prevention Lifeline. Next slide. Our correctional facility has a capacity of 825 people, but the average is right around 450 to 500. So we're working with quite a few inmates as far as finding different linkages and resources. The operation at the correctional facility includes their own internal medical staff team, including a mental health team. The reentry program that we have in this partnership with the correctional facility is one where we actually employ the reentry program manager, but that person is actually full-time over in the correctional facility where it allows all of that connection to happen. And so that person is actually part of the mental health team and collaborates very closely with them. Next slide. So how did we get to our reentry program? And this is where we start into the world of data as far as how it's really helped us. Data for us is really on a continuum. You know, there's the community level data that really drives what the needs are, but also there's that operational data and the more day-to-day piece of what helps us do our jobs. From the community-based, why we actually went down the path of reentry is because back in 2017, our county coroner kind of rang the alarm bell because, you know, we had already been working on different projects related to addressing the opioid pandemic epidemic. And one of the things that we were working on is ensuring that Narcan was widely available in our community. But in 2017, he started to notice an uptick that was different compared to past years as far as the number of opioid fatalities. And one of the targets too that he really honed in on was the presence of fentanyl in many of the overdoses. So that was definitely one piece that got a lot of people's attention. Aside from that, we also had done a workshop, a sequential intercept mapping workshop, SIM workshop. If you're not familiar with what that is, I strongly recommend and encourage that you consider looking into that. Honestly, that is one of the, I feel to be one of the more important projects that were done that allowed for us to identify what resources we had, as well as where we've had some gaps to fill. It was a 2-day workshop with a lot of different community providers, different consumers, the stakeholders, such as our criminal justice system, and it allowed for us to tease out where can we make improvements in our system. Next slide, please. So one of the many different ideas that came out of that workshop was the idea for creating a mental health substance use reentry program with the correctional facility that's here on our campus. One of the focuses that was targeted was looking at programs for people who are already incarcerated all the way through the post-incarceration phase. Next slide, please. So while the coroner provided that initial alarming data about the number of fatalities, one of the things that we had already been doing, similar to what Seth had been talking about, is creating a community dashboard that allowed for us to really be able to, you know, tell that story. I like how Seth explained that, you know, how do we tell the story so that it really is understood by people in the community that there's a real need there. So one of the things that we actually did, I'm sorry, actually, I'm not going to be able to share my screen, although I don't know, is it possible for me to share my screen?
No.
No, not going to work. Okay, that's okay. You saw, oh, that's perfectly, oh, now I'm being told maybe give it a try now. Here we go. Okay. So this is very similar to what Seth had talked about as far as their opioid dashboards and being able to collect that information and that data. And one of the programs that we do is the Dupage Narcan program that the health department, along with our Chiefs of Police Association, our state's attorney, our county coroner, and the sheriff's office. It's a partnership where we not only train people on the use of Narcan, but also supply Narcan. And this community dashboard is what has really allowed for us to demonstrate the need, specifically here in DuPage County, where we can actually track rough locations of where there were Narcan reversals. And this really helped to show, especially in a community the size of DuPage County, again, over 900,000 people, to show this is not isolated to one spot of the county. We can show and demonstrate that the use of Narcan really was happening quite widely. And these numbers represent how many of the overdoses reversals were happening in the different jurisdictions. You'll notice that some of these are outside of Dupage, and the reason for that is because we actually were supplying Narcan to other municipalities outside of Dupage who were having trouble with some of the supply. So we were actually very willing to help them out as well. And that's why you see some of those numbers. So our data is able to track over the years of how many saves we've had. So this really is what started us to be able to tell the story about why this was really important areas to focus on as far as substance use, reentry in the in the community, but then bridging into the correctional facility. At the correctional facility level, similarly, we had to show and demonstrate that the data supported that there's really a need there. And in 2017, our correctional facility partners were sharing that they had over 14,000 behavioral health contacts with inmates inside. Additionally, a pretty startling number was that people with identified behavioral health concerns typically spent almost triple the amount of time incarcerated in the correctional facility compared to somebody without a behavioral health concern. At the community or at the frontline level, our treatment providers really helped so that we could actually even look even in our own internal data, which included looking at what are the numbers of people seeking resources, what are the number of people coming in for treatment, what kind of diagnoses are we even seeing? So we were running data even at that patient level. And then, as I mentioned, with first responders, not just the data on the Narcan reversals, but really getting a feel through their conversations with them and talking about what are they seeing every day as far as what those needs look like. And that's really what led us to make that recommendation of creation of a reentry program. Next slide, please. So we started this in 2018 with the goal of identifying incarcerated individuals with mental health and or substance use. The other factor that really went into this, and we spent a lot of time in the front end, is building those relationships with our community partners. So much of reentry is really understanding what's needed following release, of course. And we created a lot of partnerships with our providers, as well as within the court system. So a lot of coordination has to happen because there's so many moving pieces. So as we all have talked about, or it was mentioned, I think right in the very beginning, it's this idea that everyone has their own data sources. How do we make it all speak together? And it's not an easy solution, but even in a county of our side, it's getting the right people to the table to be able to talk about what trends we're seeing in different parts of our data, and then finding ways to kind of bridge the information together to tell that story that helps us establish and support a program like we have. Next slide. So one of our tasks through a BGA grant that we had was to establish a screening tool system as close as we can to intake at the correctional facility. And when I say establish, I mean more of a validated screening tool. The reality is our sheriff's office was really good about collecting information about the needs of people who were coming through the booking system. However, we wanted to help get to a more validated tool that helps us be able to have a more consistent source of data so that we can not only be able to continue to tell that story about what's happening in our community, but very importantly, again, telling us how do we look at specifically the individuals? How do we identify somebody who might be in need of help even as they're coming through booking? As you all probably would not be surprised to hear, not everybody is super honest when going through a screening tool such as this that's identifying mental health or substance use needs. So another real important piece is coordinating with deputies. You really have to have, again, data can be more than just a number or counting. It's more about what are the other aspects we look for as far as concerns about somebody who might need help. So just their observation. Maybe somebody flew through their screening, but we noticed they're not feeling so well while they're maybe waiting to be assigned to a location and they start to have withdrawal symptoms. What can we do to address and help them with those symptoms as well as ongoing? And then last but not least, a very important piece is our team has direct communication with the inmates. That I think has probably been one of the most helpful aspects. Sometimes they get there and of course, nobody's ever very happy to be going through booking and being admitted into a correctional facility. But if they've been there for any amount of time, even after a few days, they settle in, they can actually reach out to us. The inmates in our correctional facility have access to tablets where the very first thing that they see on their screen is basically, I'm going to say it's like an advertisement for medication-assisted recovery. So it really identifies if you are somebody struggling with opioids, here's how you contact us. And they can actually send a message to us and we can communicate with them through that system to be able to help them get connected to the right resources. Next slide. The best practice in reentry is connecting people right at the step down, giving anybody and everybody we can that warm handoff to that next step upon release. The reality is, I keep talking about our behavioral health reentry program. It's actually one person. We only have one person there full time, Monday through Friday, who's really there to help with a lot of all of these tasks. Now, outside of the system, there's several of our staff who do fill in and help out with a lot of the follow-up once somebody has left the correctional facility. But with one person, we're only able to get so much done. About 50% of our inmates in the Dupage County Correctional Facility are actually not residents of Dupage County. We're a pretty transient county. The commuter train line goes east-west right through the middle of our county, so it's pretty easy to get from point A to point B. But that being said, it's really important that we will absolutely try to help people get reconnected to treatment or connected to treatment upon release, even if outside of our county. So one of the things that we will do is we pull together resource folders. And if we know there's going to be an inmate who's about to be released or maybe is going to be released over the weekend, we will actually print out all the treatment resources by zip code specifically to put into their files so that then they can have that provided to them after they are released. For all of the inmates who are released, they are all offered the ability to get Narcan, but especially those who we work with directly through the substance use pieces that are tagged for needs. Next slide. So whenever we are able, one of the really important things that the BGA has and COSAPP has offered us being able to do is a program that allows for us to provide MAR ahead of release. If you're not familiar with Vivitrol, it's a medication that blocks the effects of opioids. There was a study that demonstrated that people leaving a correctional facility were 40 times more at risk of overdose in the first 2 weeks after release compared to the general population. So initially, back in 2019, when we started this program, we had our correctional facility agree to let us come in and work on identifying inmates and implementing Vivitrol 10 days or so pre-release. And again, I go back to that a couple of slides ago, that coordination with our partners was critical. You know, we would oftentimes try to work with certain courtrooms to make sure that we knew ahead of time, when are we anticipating somebody being released so that we can time that injection. I'm happy to share that over the last couple of years, our correctional facility actually now supports all 3 medications for MAR. There's actually a different organization who comes in to do the methadone on a daily basis. And they too do a lot of the same stuff we do as far as those linkages leaving the correctional facility, making sure there is connection to treatment. If somebody's on buprenorphine, we are one of the providers in the community, so we do link them up with our services as well. When we're at all able to do so, and again, coordinating all of our efforts with all of the information that I qualify as data, being able to pull our resources together, what we try to do is a warm handoff right into some of our own systems. So it might not be uncommon, for example, that we could see somebody get released on say a Thursday morning. By Thursday afternoon, they might be walking right over to our crisis respite center where they can get a substance use evaluation and or mental health evaluation. And then also, most importantly, link to a prescriber to make sure those medications related to MAR are in fact all taken care of, prescriptions written, so that nothing, again, looking at that risk factor and safety. It wouldn't be uncommon as well as even on that following day, they might actually be in one of our outpatient or intensive outpatient programs. And it's not often that it all happens. I don't mean to paint a picture that this happens with everybody who comes out, but when we can really combine our resources, that is really seen to be the best case scenario. And that's something we strive for everybody. And then And if we can't do it exactly that way, we certainly will find any other creative ways that we can do that. The last thing you see there is follow-up. You know, again, sometimes people are leaving our correctional facility without us knowing, or sometimes it's even a surprise. Somebody shows up and bonds out their family member. What we will do is if we had somebody on our radar screen and they leave and we find out they leave, we will actually spend some time over the next day or two calling them, trying to get in contact with them to make sure that they got connected to the appropriate resources. And I have to say, I've been pleasantly surprised that we've actually had some really good outcomes where somebody who left before we could even get them the resources responded to our calls, said, yes, actually, I'd be grateful to get some help to get linked to somebody. And then we'll spend some time with them, getting them linked to the right resources and a link to a prescriber, especially for the opioids. Next slide, please. So just some general follow-up pieces, like I've said a few times here, you know, the data is really not just how many, which definitely helps as far as telling the story and driving home why it's so important to get in the community, but also the who, and identifying which people do we really need to work closely with. And the data sharing becomes critical at that point. And it's, you know, here we are now a couple years into one of our grants and a couple of our other programs that we've been working on. And I can't tell you that it's perfect. What I can say, it's something that we're all striving for. Each of our systems speaks a slightly different language. You know, we have a medical record system. Of course, the correctional facility has a record system. There's the court system. And for us, it's more about the people who make some of that information sharing helpful. On broader scope projects, we do definitely put our heads together and try to make the information all tell a well-rounded story about what is needed in our community. Next slide. And this last slide here is, you know, I think it's really important to highlight that, you know, reentry for us, at least, does not exist in a vacuum. You know, most of the people who are involved in our reentry, or that we actually have contact with reentry, are involved in some other program. And so our forensic behavioral health program is either directly involved or does consultation with all of these programs you see here on this slide. And I'm, you know, really happy to say that there's been just so much progress made. And this wasn't something that happened overnight. I've worked for Dupage County for over 20 years. When I first started with the county, mental health court was pretty much the main program that we could hang our hat on to say, yes, the criminal justice system is really paying attention to those with mental health concerns. Since then, all the other programs have come online, and especially so, I think, in the past 6 or 7 years. COVID definitely created a bit of a pause in some of these efforts, but the need never went away. And so we've been very happy to help out with those. But anybody who comes through reentry is often going to be involved in some other aspect of things, in which, again, it really speaks to that critical need for communication and partnering with other organizations and the criminal justice system. Next slide. Okay, that's what I thought. That was my last slide. So again, there's my contact information, and I'd be more than happy to answer any questions or provide any information you might have through email. Thank you.
Thank you so much, Mr. Latta. Great presentation. I see a lot of questions have come in. That's great. We have now entered the Q&A portion of this session. I would now like to open the floor for any questions or comments. Again, feel free to use the chat box feature to pose any questions or comments you may have. I'll open up the floor and see what we have in the chat box. Okay, first question from Rick. Since tobacco is most widely used substance and the one substance linked to leading cause of death, how might tobacco and nicotine use data be tracked in the criminal justice system, if you do track it?
We do track it, actually. It's all part of our electronic medical record system. I can tell you that one of the other efforts that we have that's more in our outpatient program, that, there's a number of people who are in our criminal justice system that might not come through some of these other programs we've talked about, but we have some real efforts towards integrated physical health care, not exclusively existing in the silos of mental health and substance use. So for example, we have treatment groups around nutrition, wellness, and that includes tobacco cessation. So it's definitely an element that we collect as far as data. As far as it actually going into specific programming per se, it's definitely more individualized at this point.
Thank you.
I was just going to say that that's something that we've just been utilizing as far as an educational standpoint, as far as cessation options and things like that for not only for those in the jails, but also in our inpatient treatment facilities as we've been going in and taking that education in there. That's the only efforts we've really been focusing on at the moment.
All right. Another question for DuPage County. How many people do you serve in long-term mental or substance use disorder recovery per year? And do you use any software to coordinate wraparound services?
So in a given year, between all of our behavioral health programs, it's typically around 8,000 or so unduplicated clients who we serve, and that's across our whole continuum. The software that we use, so we actually use an electronic medical record that coordinates all of our care. As far as the wraparound piece, it allows for us to be able to internally in all of our different programs, be able to cross-reference and see what other services somebody might be able to be involved in. I can tell you that one of the partnerships that we also have that, again, that we're just very fortunate in our community to have is we have a very strong support network, peer support network, including for even behavioral health, like NAMI, for example. Smart Recovery is pretty well established throughout our community. And so there's where we actually do, while we are the main treatment provider, and there's other treatment providers out there who we work with, by the way, too. Reentry is not exclusive just to our DuPage County system, but other providers. We rely on a lot of those peer services to help our clients as well.
Thank you, Jeff. Did you want to chime in? Yeah.
Well, I know that the same individual had asked Reno, and I answered it in text to them, but I was just going to mention that with our particular program, like the recovery response team, and then referrals to Oxford House, we had around 140 that we serviced and referred to services, and that's a pretty new program. And like I said, it's a rural area, but we're also working on developing or getting everyone, as far as our providers, on the same page as far as being able to communicate better as far as who is getting services and where. And I appreciated how Jeff pointed that out as far as non-duplicated too, so we can keep track of that better as well.
Awesome. Another question came in. What screening tools does your jail use?
So currently we use the, well, there's two separate tools. The brief jail mental health screen is used for around mental health. And we had coupled that with the TCU screening for substance use. That's in addition to the COWS, which we use very specifically, of course, related to opioids. I will say that one of the things is that when we implemented the tools, we kind of gave it a real go as far as finding what the best place is to use those screening tools. And what we are now in the process of doing is, we're kind of in that whole plan, do, check, act kind of idea of cycles of, well, what's working for us and what might be able to be improved. I will say that the brief jail mental health screen has been very easy to use and helpful, but we're still trying to figure out where is the best time and place to, in terms of the booking process for the TCU screening, and even questioning, maybe we might look at a different substance use screening as well. And partly just because of our own process. And I say our, I really should say the correctional facility process. You know, we certainly as treatment providers have some great ideas that we find and say, this would be great and so easy to use. But we also understand there's a lot of limitations, of course, based on their own operations.
Thank you, Jeff. We have about 5 minutes left. I see there are 4 more questions. What do links to treatment look like prior to release? Like classes in jail or one-on-one links to providers?
So it could be a little bit different. Our correctional facility has a substance use recovery pod. And so we provide, our treatment providers provide classes Monday through Friday in that recovery pod. But outside of that, there's of course many more inmates who are there with substance use issues. And so there are a number of supports, volunteers who go into the correctional facility through another organization to do things like AA, NA, HA, and we all coordinate together to make sure, like, okay, if they find somebody who's maybe just coming to one of those more peer level kind of supports, how do we make sure they get linked up the right way? Post-release linkage, again, very different depending on where they are going. So if it's somebody leaving the county, we try to, sometimes we'll even go so far as to see if we can schedule something if we know of a certain provider they might be working with. But other times it might be simply just giving a number, and we know that's not a real, you know, we're certainly not trying to say that we think that's like a great solution, but sometimes we feel like, well, at least we gave them that. If it's somebody within Dupage County, we have so much a better understanding of what's right in our immediate backyard. And so we are much more successful linking within Dupage County to treatment resources, including our own, which is, again, we can bring somebody over, or we're even able to do a substance use evaluation right ahead of release, so that then we can say, okay, they are eligible for outpatient, intensive outpatient, or potentially more, especially if we're coordinating with drug court to find, they might have to maybe make an order for somebody to go to a residential step down.
Thank you, Jeff.
Here in Reno County, we too have been working with the Substance Abuse Center of Kansas that has been coming into our county jail and offering peer mentor services, and also a support group that they've been holding aside from the 12-step groups that have been going in. And so that's been helping out with in particular, their coordination with the reentry coordinator at the jail to provide ones with services, whether it be inpatient or outpatient services when they get out. But most commonly, it seems like they're being referred to recovery housing like Oxford houses and such.
Thank you. We have about 3 more questions here and about 2 more minutes. So another question came in. Can you say more about how your county handles ROIs to facilitate data sharing? Are jails completing ROIs with everyone booking in? And if so, what barriers have you encountered with that process?
So I'll try to answer this in very few seconds. So if we have very client-specific information, yes, we do releases of information. We do, again, we're fortunate to be in the system we're in. So we work very closely with our state's attorney's office, who reviews and goes through all the different working agreements we have with all the different county organizations. So we are able to get aggregate data from the sheriff's office, but we cannot get client-specific data unless releases of information are completed.
Another question came in from Kirsten. What is in the overdose prevention kits that are given out?
For us, so we do a class inside the jail about Narcan. When we talk about medication-assisted recovery, we will actually talk about Narcan, and they each get a box of 2 doses. But again, it's a work in progress. They can come over to our building in the health department. We can give that out, but we're actually coordinating with the jail that we are hoping very soon where they too might be able to release Narcan right at the point of when they're leaving the correctional facility.
Seth is, I know you unmuted, about the same. All right. And then we have time for one more question. Are your programs funded by private insurance or by grant funding? And how long are your programs? 3 months, 6 months?
So we do not accept any private insurance. We are 100%, we see clients who are Medicaid or self-pay uninsured, and we do sliding fee scales and with some grants as well. As far as programs go, it depends on the level of care that's needed, since we do outpatient and intensive outpatient.
Wonderful. That is all the time that we have for Q&A. If there are any other questions that you all have, you'll have the speaker's information, and we can also share that after this webinar to send any questions, or you can send over any questions to myself. Thank you all for your questions and comments, and thank you for participating in this 3-part series. The series will be posted on the NACo website. Special thank you to our speakers today, and IIR and our funder BJA for putting on this webinar. I'd like to thank everyone and have a wonderful week.